Today's lecture is on valvular heart disease. Objective of today's lecture to identify the common acquired and congenital valvular heart disease, mainly aortic stenosis, mitral stenosis, aortic regurgitation, acute or chronic, mitral regurgitation, and congenital heart disease commonly seen in adults. First, we'll discuss aortic stenosis. So this is your heart. You can see normal structure of the heart. This is the aortic valve. Aortic stenosis. Normal aortic valve area is about 3 to 4 square centimeter. So when the aortic stenosis is developing, symptoms occur when the valve area is 1/4 of the normal area. There are three types of aortic stenosis: supravalvular, subvalvular, and valvular. Etiology of aortic stenosis are: it could be congenital, or it could be rheumatic in origin, or it could be secondary to degenerative or calcific aortic stenosis. Patients under 70 years, more than 50% have a congenital causes. Patients over 70 years, 50% are due to degenerative or calcific aortic stenosis. When you consider the etiology of aortic stenosis, these are the congenital aortic stenosis, and congenital bicuspid valve is a common cause of congenital aortic stenosis. Acquired conditions are degenerative calcification, rheumatic heart disease, that's a chronic rheumatic heart disease, and some other rare causes also like Paget's disease, SLE, rheumatoid arthritis can cause acquired aortic stenosis. So this is the aortic valve. Here you can see normal aortic valve having three cusps. This is the bicuspid aortic valve. You can see one valve here. This is the second valve. So it is a bicuspid aortic valve. When aortic stenosis happening, you can see in senile aortic stenosis, the sclerosis of the valve cusps and become firm and reduce pliability also. Here you can see some advanced stage of the bicuspid aortic stenosis. You can see there is a thickening of the valve leaflet. It's a real situation. Here you can see three cusps of the aortic valve, and you can see there's a thickening. So pathophysiology of aortic stenosis. When there's a aortic stenosis, there's a pressure gradient developed between the left ventricle and aorta. So there's an increased afterload. Left ventricular function initially maintained by compensatory pressure hypertrophy. So left ventricular wall become hypertrophy, and when it is going for some time, what happens when compensatory mechanism exhausted, left ventricular functions decline. So what are the common symptoms of significant aortic stenosis are syncope, angina, and dyspnea. Those are very important symptoms of aortic stenosis patient. The physical findings of patient with aortic stenosis are pulse, slow rising carotid pulse, we call it as a pulsus tardus, and decreased pulse amplitude, we call it as pulsus parvus. Heart sound, soft and split second heart sound, and S4 gallop due to left ventricular hypertrophy can be heard. And there will be a systolic ejection systolic murmur, which is crescendo decrescendo character. This peak later as the severity of the stenosis increases. Remember, loudness does not tell anything about the severity of the stenosis. So what is the natural history? So from mild aortic stenosis to severe aortic stenosis, the natural history, 8% of people in 10 years time develop to severe aortic stenosis. 22% of the people from mild to severe develop within 22 years time, and by 25 years time about 38% mild aortic stenosis will develop to severe aortic stenosis. And the onset of symptom is a poor prognostic indicator. So like syncope, angina, and faintishness, like symptoms are bad prognostic signs. What happens when the patient is asymptomatic during this period? When the patient start to develop symptom, there is a rapid deterioration of the clinical condition. And if you replace the valve, we can improve the survival of the patient. How to evaluate a patient with aortic stenosis? So first the history examination, then the echocardiogram is very useful. It's the most valuable test for diagnosis, quantification and follow up a patient with aortic stenosis. Mainly two measurements obtained are left ventricular size and function. So left ventricular hypertrophy, dilatation and ejection fraction you take, and then the Doppler derived gradient and the valve area is very important. So this summarize by taking the echo findings. This is how you grade mild, moderate, severe aortic stenosis. This is aortic valve area. This is a velocity. Uh, no need to remember in your stage, but when you do in the postgraduate, you have to remember these values. So how to manage patient aortic stenosis? General principle: patient need infective endocarditis prophylaxis. Medical management: it has a limited role since aortic stenosis is a mechanical problem. So vasodilatation are relatively contraindicated in severe aortic stenosis patient. Aortic balloon valvulotomy, it shows little benefit, and surgical replacement is the definitive treatment. So when you do the patient with the aortic stenosis, when you do the follow-up echo, if mild aortic stenosis, every 5 years you have to do follow-up echo. Moderate aortic stenosis, every 2 years you have to do repeat echo. And severe aortic stenosis, every 6 months to 1 year you have to repeat the echo and see the development of aortic stenosis. So what are the indications for aortic valve replacement in aortic stenosis? The class 1 indications are symptomatic patient with severe aortic stenosis, patient with severe aortic stenosis undergoing coronary artery bypass grafting or surgery on aorta or other valves, then you have to consider aortic valve replacement. Third indication is patient with severe aortic stenosis and depressed left ventricular ejection fraction that is less than 50%. So those three are the class 1 indication for aortic valve replacement. Class 2 indications are patient with moderate aortic stenosis undergoing coronary artery bypass grafting, surgery of aorta or other heart valve surgery. Second indication is an asymptomatic patient with severe aortic stenosis with abnormal response to exercise or critical aortic stenosis or high likelihood rapid progression due to age, calcification of coronary artery disease. So these are the indication for aortic valve replacement. In simplified version, these are the indication for aortic valve replacement. Any symptomatic patient with severe aortic stenosis go for aortic valve replacement. Any patient with decreasing ejection fraction go for aortic valve replacement. Any patient undergoing coronary artery bypass graft with moderate or severe aortic stenosis go for replacement. These are the valve types. We are going to replace metallic valve types. Here how you insert the valve. So in summary, the aortic stenosis is a disease of aging. Look for the signs on physical examination. Echocardiogram to assess the severity is very useful. Asymptomatic patient, medical management and follow-up echo and other investigation. Symptomatic patient, aortic valve replacement is mandatory even patient is in old age. Now let's move to the next topic. It is a mitral stenosis. Definition: obstruction of left ventricular inflow that prevent proper filling during diastole. Normal mitral valve area 4 to 6 square centimeter. Transmitral gradient and symptoms begin at area less than 2 square centimeter. So when the valve size area size becomes smaller, patients start to develop the symptom. Rheumatic carditis is the predominant cause even in Sri Lanka. Prevalence and incidence decreases due to reduction of rheumatic heart disease in Sri Lanka and most of the developing countries. So when you consider the etiology of mitral stenosis, as I said, commonest is a chronic rheumatic heart disease. It accounts for about 77 to 99% of all cases, and clearly infective endocarditis and mitral annular calcification also can present like a mitral stenosis. This is a mitral valve. Here you can see the cusp, and these are the coda tendineae. So you can see roughening of the mitral valve. Echocardiogram, this is the left atrium. This is the mitral valve. This is the anterior mitral leaflet. This is the posterior mitral leaflet. This is the left ventricle. This is the right ventricle. And close up view, here you can see this is the left atrium. This is the anterior mitral valve, posterior mitral valve. You can see those are thickened, calcified, and those are very bright when you do the echo examination. It's a cross-sectional echo. Here, this is the thickened, narrow mitral valve orifice. This is the orifice. So this is a real picture. Here you can see mitral valve. This is the orifice. Mitral stenosis pathophysiology. Patient can present with a progressive dyspnea, about 70% of the patient. Why? Left ventricle become dilated when there is a pressure gradient, and as a result of that, back pressure increases and pulmonary congestion. And it works with exercise, fever, tachycardia, and pregnancy. When there is an increased transmitral pressure, it leads to left atrial enlargement and atrial fibrillation. When patient is having long-standing the mitral stenosis, right heart failure symptoms develop due to pulmonary venous hypertension. And patient can present with a hemoptysis due to rupture of bronchial vessels due to elevated pulmonary pressure. So what is the natural history of mitral stenosis? Mild mitral stenosis 10 years after initial rheumatic heart disease insult. So after 10 years time, patient can get a mild mitral stenosis symptom. And about another 10 years later, they can get a moderate mitral stenosis symptom. Another 10 years later, you can get a severe mitral stenosis symptom. Mortality due to progressive pulmonary congestion, infection, and thromboembolism like stroke. What are the other physical examination findings of mitral stenosis? Prominent A wave in jugular venous pulsation. Patient can get a signs of right-sided heart failure, and patient can get a mitral phases. Mitral phases develop when mitral stenosis is severe and the cardiac output is diminished. There is a vasoconstriction resulting in pinkish purple patches on cheek. So the heart sound when you auscultate, diastolic murmur is the most important hallmark of the disease. Low pitch diastolic rumbling most prominent at the apex, heard best when the patient lying on the left side and breath held in expiration. Intensity of the diastolic murmur does not correlate with the severity of the stenosis. And you may hear the loud opening snap at apex when valve leaflet are pliable. It is due to abrupt halt in leaflet motion in early diastole after rapid initial rapid opening due to fusion at the leaflet tips. A shorter S2 to the opening snap interval indicate the more severe disease. So the from second sound to the opening snap, if that interval is depending on that interval, if it is shorter, it says more severe aortic stenosis, not the sound or the loudness of the murmur. How to evaluate a patient with mitral stenosis? ECG, chest X-ray, echo are routinely done. ECG may show atrial fibrillation or an evidence of left atrial enlargement. You may see it as an M pattern. Chest X-ray, left atrial enlargement and pulmonary congestion, and occasionally calcified mitral valve. When the left ventricle enlarged, you may see as a double shadow. Echocardiogram is a gold standard for diagnosis, and it will assess the mitral valve mobility, gradient, and mitral valve area. So these are how you grade the mitral stenosis according to severity. As I said earlier, just have some idea, but no need to remember. How to manage the patient with mitral stenosis? Serial echocardiography is important. Mild patient, 3 to 5 years time you repeat the echo. Moderate disease patient, 1 to 2 years. And severe disease patient, annually you have to do repeat echocardiogram. What are the medication? Mitral stenosis, like mitral atrial stenosis, is a mechanical problem, and medical therapy does not prevent progression. Beta blockers, calcium channel blockers, digoxin, which control heart rate and hence prolonged diastole for improved diastolic filling, will be useful. Diuretics can be used for a fluid overload. So the identify the patient early who might benefit from percutaneous mitral valvulotomy is important. So that's why you have to do repeated echo frequently. Endocarditis prophylaxis when patient is having prosthetic valve or who had a past history of endocarditis may need endocarditis prophylaxis. So this shows mitral valvulotomy, balloon valvulotomy. An indication for intervention in mitral stenosis. So when I going to do surgery, so class 1 indication, symptomatics, moderate to severe mitral stenosis with acceptable operative risk when percutaneous mitral valvulotomy is not available or contraindicated or unfavorable anatomy is present, you go for a surgery for symptomatic moderate to severe mitral stenosis patient. A symptomatic patient with moderate to severe mitral stenosis with concomitant severe mitral regurgitation, you go for surgery. So this is the severe moderate to severe mitral stenosis plus mitral regurgitation. Class 2 indications are mitral valve replacement for symptomatic patient with severe mitral stenosis and severe pulmonary hypertension who are not candidate for percutaneous intervention or surgical commissurotomy. Second indication is mitral valve repair for asymptomatic patient with moderate to severe mitral stenosis who have had a recurrent embolic event while receiving adequate anticoagulation with favorable anatomy for repair. Class 3 indication, mitral valve repair is not indicated for mild mitral stenosis. So, mild mitral stenosis patient, we don't do mitral valve repair. So, in simpler way, any symptomatic patient with NYHA class 3 or 4 need mitral valve replacement. Next, we'll move to the next valvular heart disease, aortic regurgitation. So this is the aortic valve. So this is the regurgitation jet. When you do the echocardiogram, this is the aorta, this is the left ventricle, this is the aortic valve. So this is the regurgitation jet during diastole. So definition is leaking of the blood into left ventricle during diastole due to ineffective close of the aortic cusp. Etiology for acute aortic regurgitation. This is acute aortic regurgitation, endocarditis, aortic dissection. So in acute aortic regurgitation, physical findings will be wide pulse pressure, diastolic murmur, torrid pulmonary edema. This is an acute emergency. And treatment of acute aortic regurgitation, it is a true surgical emergency. You may need positive inotrope like dopamine, dobutamine, vasodilators like nitroprusside. You have to avoid beta blockers. Do not even consider balloon pump in this patient. When you come to the chronic aortic regurgitation, which is a commonly seen in practice, it is due to bicuspid aortic valve, chronic rheumatic valvular heart disease, and infective endocarditis. Pathophysiology. There's a combined pressure and volume overload is seen in chronic aortic regurgitation, and compensatory mechanism operates as a result of that. Left ventricular dilatation, left ventricular hypertrophy can be seen, and progressive dilatation leads to heart failure. What is the natural history of chronic aortic regurgitation? Usually they are asymptomatic until 4th and 5th decades. Rate of progression 4 to 6% per year. Progressive symptoms include dyspnea, nocturnal angina, and palpitation. So dyspnea mainly exertional, orthopnea and paroxysmal nocturnal dyspnea can happen. Nocturnal angina due to slowing of heart rate and reduction of diastolic pressure. Palpitation is due to increased force of contraction. Those are the common symptoms patient will experience. Physical examination finding in chronic aortic regurgitation, you may get a wide pulse pressure. It's very sensitive. When you feel the pulse, you get a bounding pulse and look for the collapsing pulse. So the hyperdynamic and displaced cardiac apical pulses you can see. When you auscultate, you can get a diastolic blowing murmur at the left sternal border. And you may hear the oscillatory fit murmur at apex due to it is a diastolic murmur due to regurgitation jet impinge on anterior mitral valve leaflet causing it to vibrate. Then you hear the diastolic murmur. There's no real mitral stenosis, but you will hear like a diastolic murmur. And then you may hear the systolic ejection murmur due to increased flow across the aortic valve. When you're doing the some examining the aortic regurgitation patient, there are some interesting physical findings. So these are those interesting findings. You better remember these. Sometime we will ask in the exam. Ostentatious murmur, as I said, it's a low pitch apical mid-diastolic rumbling murmur. Then other things like Corrigan sign, pulse, Durosia sign, Hill sign, Main sign, Trueb sign, Quink's pulse, Muller's sign, De Mosset sign. Those are the some interesting signs we may ask in the exam. So you have to know what De Mosset sign is, a visible bobbing of the head. Like that, you have to remember this sign and the explanation. When you are doing the investigation, the patient with the chronic cardiac regurgitation, chest X-ray is useful. It will show enlarged cardiac shadow and aortic root enlargement. Echocardiogram is the most important. It evaluates the aortic valve, aortic root with measurement of left ventricular dimension and function also. Aortography used to confirm the severity of the disease. Again, you can see the grading of the aortic regurgitation, mild, moderate, severe, according to the echo findings. So again, no need to remember, just go through this, but no need to remember. How to manage the patient with aortic regurgitation? In general principle, infective endocarditis prophylaxis in dental procedures with prosthetic aortic valve or history of endocarditis patients, you may have to consider endocarditis prophylaxis. Medical management, vasodilators like AC inhibitors, nifedipine-like drug improve stroke volume and reduce regurgitation only if patient symptomatic or having hypertension. Serial echocardiogram to monitor the progression of the disease. And surgical treatment will be the definitive treatment. So indication for aortic valve replacement in aortic regurgitation are the class 1 indications are symptomatic patient with severe aortic regurgitation. Second, patient with severe aortic regurgitation undergoing CABG or surgery on aorta or other valves. Third indication, asymptomatic patient with severe aortic regurgitation and left ventricular dysfunction. Class 2 indications are asymptomatic patient with severe aortic regurgitation with normal left ventricular ejection fraction but severe left ventricular dilatation. Second indication is patients with moderate aortic regurgitation undergoing CABG or surgery of the aorta or other heart valve surgery. Then you can consider aortic valve replacement also. So this is a flow chart. So when you diagnose aortic regurgitation, see whether it's acute or chronic. So if acute, refer for the emergency aortic valve replacement. Chronic, then see whether patient is some symptoms. If it's a chronic severe aortic regurgitation, symptomatic, yes, then go for aortic valve replacement. If asymptomatic, go on this pathway. Mild to moderate aortic regurgitation, follow this pathway. So in simplified version of the indication for surgery in patient with the aortic regurgitation are any symptoms at rest or exercise, go for aortic valve replacement. Symptomatic treatment if ejection fraction asymptomatic patient if the ejection fraction less than 50% or left ventricle become dilated, again go for aortic valve replacement. So these are the indication for surgery in patient with the chronic aortic regurgitation. Then we'll move to the another cardiac defect, that is a mitral regurgitation. Acute mitral regurgitation commonly due to endocarditis, acute myocardial infarction and malfunction or disruption of prosthetic valve. How to manage the acute mitral regurgitation? So if the due to myocardial infarction, treat for the myocardial infarction. And most other causes of mitral regurgitation is the treatment aim is a reduction of afterload. So use the diuretics and nitrate, nitroprusside even in the setting of the normal blood pressure. So do not attempt to alleviate tachycardia with beta blockers. It is contraindicated, and mild to moderate tachycardia is beneficial in these patients because it allows less time for heart to have backfill, which lower the regurgitation volume. So treatment for the acute mitral regurgitation, balloon pump, nitroprusside even in the hypotension, emergency mitral valve surgery. Then move to the chronic mitral regurgitation. Mild physiological type of mitral regurgitation seen in about 80% of the normal individuals. So it's a common to have trivial mitral regurgitation. What are the common causes for the chronic mitral regurgitation? Mixed matter mitral valve, that is a mitral valve prolapse. ischemic mitral regurgitation, rheumatic heart disease, infective endocarditis. So pathophysiology of chronic mitral regurgitation, it is due to pure volume overload. And there will be compensatory mechanism like left atrial enlargement, left ventricular hypertrophy and increased contractility, and there will be a progressive left atrial dilatation and right ventricular dysfunction due to pulmonary hypertension. Progressive left ventricular volume overload leads to dilatation and progressive heart failure. What are the physical findings of mitral regurgitation? Auscultation, you may hear the first soft heart sound, then hollow systolic mitral regurgitation murmur at apex, which is commonly radiated to the axilla. You may hear third heart sound, and chronic mitral regurgitation, the intensity of the murmur does not correlate with the severity. Patient will experience exertional dyspnea, and patient may develop the features of heart failure. And what is the natural history of mitral regurgitation? There will be a compensatory period of about 10 to 15 years, and then patient will become symptomatic. Patient with asymptomatic severe mitral regurgitation have a 5% annual mortality rate. And once the patient ejection fraction less than 60 and or becomes symptomatic, mortality rises sharply. Mortality from progressive dyspnea and heart failure. Mainly, heart failure give rise to death of this mitral regurgitation patient. What are the investigation we do for the patient with mitral regurgitation? ECG, chest X-ray, echo. ECG may show left ventricular enlargement, atrial fibrillation, and left ventricular hypertrophy with severe mitral regurgitation. And chest X-ray, left atrial enlargement. There may be a pulmonary artery enlargement in the chest X-ray. Echo is very useful. It estimates left atrial, left ventricular size and function. Valve structure assessment also can be done. You can group for the transesophageal echo if transthoracic echo is inconclusive. Again, the grading of the severity of mitral regurgitation, you can see mild, moderate, severe according to the echo findings. You can go to, but no need to remember. How to manage chronic mitral regurgitation? Medication. Vasodilators like hydralazine, rate control for atrial fibrillation with beta blockers, calcium channel blockers, and digoxin. Anticoagulation in atrial fibrillation flutter patient. Diuretics for fluid overload. When you are managing patient with mitral regurgitation, you may need to do serial echocardiography. If the patient condition is mild, 2 to 3 yearsly you have to repeat the echo. If the mitral regurgitation is moderate, 1 to 2 years you have to repeat the echo. If the mitral regurgitation is severe, you have to do every 6 to 12 months repeat echocardiogram. Endocarditis prophylaxis for a patient with prosthetic valve or patient who is going for a dental procedure. So here you can see the indication for surgical replacement of the mitral regurgitation. You can see class 1 indication, acute symptomatic severe mitral regurgitation, go for the valve replacement. Then chronic severe mitral regurgitation patient with a symptomatic patient, NYHA class 2 to 4. In the absence of severe left ventricular dysfunction, you go for a valvular intervention. Asymptomatic patient with mild to moderate left ventricular dysfunction, ejection fraction 30 to 60, you go for valvular replacement. Mitral valve repair preferable to mitral valve replacement if repair is feasible. And class 2 indications are asymptomatic chronic severe mitral regurgitation, like new onset of with the new onset of atrial fibrillation, pulmonary hypertension, like condition, you have to think about mitral valve replacement. This is a flow chart to summarize the management of mitral regurgitation. You can go through this. And in simplified way, what are the indications for mitral valve replacement in severe mitral regurgitation? Any symptomatic at rest or exercise, if repair is feasible, go for repair, otherwise replacement. Asymptomatic patient, if the ejection fraction less than 60 or if new onset of atrial fibrillation, we go for a valve replacement. Now let's move to the adult, the congenital type of heart disease. This is a common condition again. People start congenital heart disease, but a lot of adult patients are there with congenital heart disease. And congenital heart disease is an abnormality of the heart that is present at birth. It may be heritable or due to some influence occurring during the pregnancy. 95% of the people have no identifiable cause. They range in severity from fairly simple to the and curable to very complex and potentially lethal type of congenital heart disease. Congenital heart disease is the most common type birth defect, occur in 1 in 100 births. When you see American data, 32,000 new cases of congenital heart disease every year, and 1.5 million worldwide people having congenital heart disease. 20,000 open heart operation annually doing for the congenital heart disease. More than 85% of the people with congenital heart disease reach adulthood. Approximately 1 million adults with congenital heart disease live in America. More adults than children with congenital heart disease can be seen because of the advancement of the treatment. Common congenital heart disease type we are going to discuss: atrial septal defect, ventricular septal defect, endocardial Cushing disease, patent ductus arteriosus. So when you consider the congenital heart disease, one type is a cyanotic congenital heart disease where right to left shunt is there. There's an obstruction to the pulmonary blood flow. Examples are tricuspid pulmonary atresia and pulmonary atresia. There is an intracardiac mixing of oxygenated blood with the unoxygenated blood, like tetralogy of Fallot, transposition of great vessel, and single ventricle. So, obstructive type of valve lesions are the pulmonary valve stenosis, aortic valve stenosis, coarctation of thoracic aorta. So, this is a normal structure of the heart. In atrial septal defect, there is a defect bit in the atrial septum, and because of that, there is a mixing of the blood. This is a ASD defect. The defect, the location can be vary. So this one is a premium defect. This is the secondum defect. Third one is a superior sinus venosus defect. This is a inferior sinus venosus defect. This is a ostium primum. This is the ostium secundum defect. And here you can see. So you can correct this by patch repair. So this is the repair to close this defect. And this is how the amplifier occlusion of the atrial septal defects. You insert this and this is a mesh like thing. So then you put the mesh there and remove this introducer. So this is how you close the uh, atrial septal defect. So what is survival pattern of atrial septal defect? Normal if the close before 20 years of age. If you close this defect between 25 to 45 years, there's a good prognosis. If defect close after 45 years, increased mortality and morbidity can be seen. So earlier the closer is better. So what happened to ASD if not treated? They can get a pulmonary hypertension, and occurs in two chronological disparate age group. First thing is if the female with the pulmonary hypertension come across during your clinical examination and late teens and 20s. If it's a pulmonary hypertension with coincidental ASD, so that means patient is having pulmonary hypertension that is not secondary to ASD, pulmonary hypertension plus coincidental ASD, then better to leave this ASD open. It will help the patient. If the patient is more than 40 years and mild to moderate pulmonary hypertension, secondary to long-standing left to right shunt, that kind of patient benefit from crossing the ASD. So the patient with the pulmonary hypertension, see whether it's a primary pulmonary hypertension or secondary. Pulmonary hypertension with ASD, leave the defect open, and if the pulmonary hypertension with secondary to ASD, then benefit by closing the defect. Next defect is a ventricular septal defect. Again, this is the interventricular septum. This is the defect, and this is the closure. So the defect, the location can vary. So this is a perimembranous defect, is an inlet defect, central muscular defect, anterior muscular defect, apical defect. So when you going to close, again this is the device you are using to close the defect, and then after defect, patient get a good prognosis. Then another adult patient you can come across with is a patent arteriosus. Here is the patent ductus arteriosus, and so as a result of this, patient get a continuous murmur. So the ligation can be done when we are correcting this defect, and or coil you can embolize to cross the defect, or otherwise you can do some yes, those are the main thing doing to correct the patent arteritis arthrosis. This also can come as a this kind of patient can have as an adult patient with a continuous murmur. Then the Marfan syndrome also can get some involvement of the heart. If you come across a very tall patient with the Marfanoid hepatitis, always look for the cardiac involvement, especially mitral valve prolapse is a common association in Marfan syndrome. Coarctation of aorta also can present like a young hypertensive with a systolic murmur, ejection systolic murmur. So this is a coarctation. There's a narrowing of the great artery, the aorta, and clinically, most of the time, those are repairable, and they present usually with a hypertension or a murmur. And when you feel the pulse, you may get a weak or delayed low extremity pulse. And rib notching at the X-ray is a common finding, which is very pathognomic. Here you can see rib notching enlargement. Here you can see rib notching. So coarctation repair can be done by various procedure. We don't ask from you in the exam, but know that we can surgically repair the coarctation. Different approach. This is the subclavian flap approach. Here, this is the flap. So various ways you can do it surgical correction. And also for the coarctation, we can do the aortic coarctation angioplasty. Here you can see put in the balloon, and otherwise you can put a stent and leave the coil there in the artery to prevent the collapse of the artery. Then some words about the Eisenmenger syndrome. This is important to know. Final common pathway for all significant left to right shunting kind of congenital heart disease. Final common pathway is Eisenmenger syndrome. When Eisenmenger syndrome happens, there is a right to left shunting and the cyanosis develop. So this is the pathway of Eisenmenger syndrome development. When there is a left to right shaft initially due to congenital heart disease, acyanotic congenital heart disease, there's an increased pulmonary blood flow. As a result of that, endothelial dysfunction and pulmonary vascular remodeling happen. Then increased pulmonary vascular resistance. As a result of that, inverted shunt right to left. Initially it is left to right, now it is a right to left. Then patient will develop Eisenmenger syndrome. Patient becomes cyanose. What are the complications of Eisenmenger syndrome? Coagulopathy, platelet consumption, brain abscess, cerebral microemboli, airway hemorrhage, especially moving from lower to high altitude condition, patient can get airway hemorrhage. So again, complications are hyperviscosity, cerebrovascular accident, that's a stroke, hemoptysis, renal dysfunction, hyperuricemic and gout, hypertrophic osteoarthropathy, cholestasis, and hemostatic abnormalities. Here you can see if you don't treat, this is going to happen. The mortality rate increase, but with advanced therapy, you can reduce the cumulative mortality rate. So how to treat? If polycythemic, think about the phlebotomy and rule out any correctable diseases. If so, correct that. Once diagnosis is established, avoid aggressive testing as many such patients can die during the cardiovascular procedures. So once diagnosed, no need to do the aggressive investigation. If you need it, you can give diuretics and oxygen. And definitive treatment is heart lung transplantation. Here, the Eisenmenger treatment summarization. So, patient will start to develop the heart failure symptom from NYHA 2, 3, and 4, gradually worsening of the heart failure, and patient can die. And what are the supportive therapy you can think about? Periodic assessment by trained cardiologists, evidence of dehydration and preservation of fluid balance, endocarditis prophylaxis, evidence of pregnancy, adequate contraception, regular immunization against influenza and pneumococcal infection, treatment of iron deficiency and relative anemia, avoidance of strenuous exercise, especially high static, staying active within the support symptom limit, relief of hypovisceral syndrome, anticoagulation only if other indication present. So when you are treating, so you can initially think about bosentan like drug, and later on you can add PDE inhibitors like sildenafil. And if the patient is continuous to deterioration, then think about the heart lung transplantation, which is even not happening in Sri Lanka. Only we did the one heart transplantation, but we are not routinely doing that. What are the poor prognosis markers of adult patients with Eisenmenger syndrome? Young age at presentation, complex congenital heart disease, Down syndrome, right ventricular hypertrophy on surface echocardiography, elevated mean arterial pressure, reduced systolic blood flow, poor functional capacity, syncope, supraventricular arrhythmia. So remember this indication can be asked like a MCQ also. When you consider pregnancy, it is very important. Pregnancy and Eisenmenger syndrome very important. Preconceptional, what you have to do, basically pregnancy is contraindicated, and you have to prescribe contraceptive method which is suitable for the patient. Progesterone therapy indicated, but estrogen therapy is contraindicated. Sterilization procedure is risky. Termination to be done ideally in the first trimester if patient accidentally pregnant. Advanced therapy may be used, but bosentan is contraindicated during pregnancy. If patient become pregnant, antenatal care, thromboprophylaxis is advisable, close monitoring, bed rest after 20 weeks of gestation, advanced therapy according to the patient, fetal echo at 20 weeks of gestation. During the what is the intrapartum care, ideal mode of delivery is controversial. Fluid management is important during the delivery also. Epidural analgesia is prepared over the general anesthesia. Oxytocin to be avoided. PPH to be watched carefully. So today lecture is very important for you because based on this lecture you will get a short case in your exam. Again, you will come across several MCQs based on today exam, today lecture. Thank you very much.